earwax is typically a light brown shade, and as that earwax matures and ages, it oxidizes, so it reacts with oxygen. And just like an apple or an avocado, once you've cut into an apple or an avocado, and if you don't put it in some water with some lemon juice, some acid, it begins to oxidize. Similarly with the earwax, it turns darker. And this patient's earwax is also slightly sticky and wet. It is lodged very deep in the ear. So it's one of those ears that we call it a very messy ear. You go in there and it's all coating the canal wall. It's sticky, it's sloshy. You can just see there with the suction probe, it's very difficult to suction this. It's almost like a wet mud consistency. And instead of suctioning, you get some of the wax that sticks to the tip of the suction probe. And when you move the suction probe away, it just pulls it in strands almost. Almost like a chewing gum when you stretch it. Sounds weird, but if you're a doctor, a medic, you have a stool chart, and a stool chart, you get different consistencies of your stool, and I forgot how many there were, but different types of stool. By examining your stool, a doctor can sometimes have an inclination about your overall health and well-being, and not in the same way as earwax, but I'm not suggesting that earwax, the type of earwax you have, it might be, I'm not sure, but I doubt it. It doesn't give you an inclination of your underlying health condition, but because there's so many different types of wax, it would be good to have a grading system, and that's something I might just develop. Typically wax is either categorised as wet or dry, but there's so many different subcategories, and it'll be good just to develop a grading system for different types of wax. So as soon as, if I say grade 2 type of wax, one would know straight away what type of consistency it is. The grading system actually in medicine is sometimes also, well, not sometimes, it is actually used to also help diagnose the severity of a condition. So in terms of ears, we have keratosis obturans, which is a build-up of a dead skin plug, and you get different grades of that. Grade 1 is very mild, grade 4 is very severe. But the stool chart is slightly different. It's not about the severity, it's the type, the consistency. So I'm just plodding along here, just trying to get this off the canal wall. I think I'm going to use some olive oil drops. Now, it was lodged very deep in the ear canal towards the eardrum, and we've just brought that away there. The patient has got quite a narrow ear. You can probably tell that actually. We've got a full zone of suction probe in the ear, and it's not much giveaway there, not much space. So I've just put some oil in. Sometimes the oil, not only does it bind the wax together, but imagine you've got a ring on your finger that's stuck. You put a bit of soap there, and it just helps lubricate the finger and the ring, and you can slowly remove the ring off your finger. Similarly, the oil can work like that in the ear. So we clean the ear. It's just a bit of wet around the edge, so we're just going to mop that up as much as we can. But the eardrum's nice and healthy. Patient can hear significantly better. And that gives you a good idea of how narrow the ear is. That's a full zone of suction probe, and it just about fits into the ear canal. So it's very little give, very little space available once it's in. Yes, and there's a bit around the edge. I'm not going to get all of it out. It's not going to cause the patient any symptoms. A bit of wax is actually good for us. Lovely healthy eardrum, lovely light reflex. So that's patient 1. This is patient 2 now. This is patient 2. We're going to perform it in the left and right ear. So we're starting off in the patient's left ear. Now they have otitis externa. Otitis externa is an umbrella term for an outer ear infection. So the term otitis means ear infection. Externa means the external part of the ear, so the outer part. If you have otitis media, the media means in the middle ear. And the patient's got this otter ear, so ear pulse that was lodged against the eardrum. So we just cleared that now. You can see all the dry skin around the edge of the ear canal. And deeper, it's all wet and gooey. So we are going to go back in a moment and just suction off all the muck of the eardrum. The eardrum's not fully visible as yet. It's still covered by this discharge. When you've got otitis externa, the ear temperature's raised, so we do get a slight fogging of the endoscope lens, but as soon as you go in with a sucker, that dissipates. So we're just, again, the patient's got a very narrow ear canal. There's not much space there. This is a fine end gauge. And again, a fine end gauge in the ear, near the eardrum, there's very little space available. And we want to avoid touching the bony part of the ear canal because of how gentle I am. So we can see the malleus bone, the hammer bone, the eardrum itself, the majority we can see now. Slightly opaque, so slightly scarred. The patient has already got a course of antibiotics from their doctor. There's just some dead skin medially. Just going to gently peel this. We're going to be ever so gentle here. So when someone presents with otitis externa, you can more or less guarantee they've got earache, pain in the ears. So we've got to be careful not to add to that. And there's just some discharge here on the eardrum. You can see we just gently took that directly off the eardrum. We're very pleased with that now. I can just trying to fit the fine end into the anterior recess. It's just about fitted. I think there's just some here in the anterior superior portion of the eardrum. So that eardrum's all visible now. It's nice and clear. And hopefully with the antibiotics the patient has, that will clear up. I think I'm just going to mop up around the entrance now, so all this dry skin. So this is another hallmark of otitis externa. It's something you can get psoriasis, a bit of eczema if you like. You see it's a bit more red, it's a bit more tender than a normal healthy ear canal. And in a moment we're going to perform a dead skin extraction off the patient's right eardrum. So it wasn't fully occluding, it's coming up in a moment hopefully. Okay, you can just about fit the endoscope in the ear, it's that narrow, so I'm very, very pleased with that. So this is the same patient, this is the right ear. So this ear canal is a bit wider, it's the fine end we're using, it's a lot more space, you can see the difference. This ear canal is obviously not infected, it's not inflamed like the other one. That's part of the reason why the other is narrow, but this has some dead skin directly on the drum. So this skin would have formed the outer layer of the eardrum, and this, as the skin dies and shed, it should move sideways outwards, and underneath you have a fresh layer of the eardrum. However, that skin didn't migrate, it was just resting on the eardrum. So this is patient 3 now, so it's just a pre-procedure video. It's going to start off in the left ear. The wax, the patient had been using some drops, it's very wet. You can see this plug of wax is enveloped by some dead skin, keratin. So this keratin would have been the outer layer of the ear canal. And as that skin dies, it should shed and move sideways out of the ear naturally. But in this case, it's enveloped itself, it's engulfed itself around the plug. And that's what gives it the glossy appearance. So came out pretty straightforward. See the eardrum already. So we're just going to mop up some of this wet wax. So this is the first bend, the cartilage I'm touching to the right, where all the hairs are on the right here. That's the first bend of the ear canal. Just to the left, about 0.5 centimetre further in, you can see the canal on the left. That's the second bend. So that's the second bend just there. And this is the isthmus on the left. You can see the ear canal just protruding inwards a bit. So if you've been watching my videos, I'm always trying to educate the viewers. So the ear canal is like an S bend. We got 2 bends. The bends, the S shape is designed to protect the eardrum. So if you have an object that enters the ear, it can't directly penetrate through the eardrum. The first bend is about 0.5 centimetre into the entrance of the ear canal. The second bend is a further 0.5 centimetre, and where the second bend is in the ear canal, that's where the bony part of the ear canal, so the inner 2/3 is made up of bone, that's where that meets the outer third of the ear canal, the cartilaginous portion. They call it the osteocartilaginous junction. And then about 0.5 centimetre away from the eardrum, we have another natural narrowing of the ear canal, and the ear canal then widens again. We call that the isthmus. It's the same patient right here. We've got the plug of wax out already. It's a bit dry. I've not been using as much drops. So the eardrum's healthy. Just some dead skin. We're just going to try and peel this off as much as we can, as safely as possible. If we don't get it all out, we're not going to worry too much. This is more preventative because the skin is unlikely to come out by itself now. So I'm just trying to give it a helping hand, even if sometimes we lift it off the canal. But this skin is strongly adhered. It's really, really strongly adhered. So the skin that lines the inner 2/3 is a lot thinner than the skin that lines the outer third. And it's really, really adhered to the bony part. So it's almost like double-sided sticky tape, this. We're going to be really, really careful as I'm trying to peel this off. And I have to put a lot of force in to avoid the canal wall. Because if we touch that canal wall, it's going to hurt the patient and they won't be happy. So I'm happy with that. We're not going to get any more out. We don't want to go any further. And get some, when we're on the outer third where we're higher, we can put a bit more force. We can actually touch the ear canal here. It's not going to be uncomfortable for the patient. So the outer third of the ear canal, the cartilaginous portion, it's semi-sensitive. The skin's a lot thicker. It's about 1 centimetre in thickness, so it gives it it's like a buffer effect almost. Yeah, we're just mopping up around the edge. Lovely healthy eardrum. So these ear hairs, it can actually, they sometimes can be like whiskers. They normally grow on the back part of the ear canal near the entrance on the cartilaginous portions. The hairs should only be found on the cartilaginous portion. That's where the hair follicles are. There shouldn't be any hair follicles on the bony part, the inner 2/3 of the ear canal. Again, we're just mopping this up very quickly.